Thank you very much for the invitation. Sorry that I didn't get up here earlier, but we're doing it using our newfound sort of skills. So I'm just going to share my screen, which will work perfectly well 5 minutes ago. So let's see if it works again. And share. Okay, that's come up. Right, I'm just moving that up there so I can see my slides. I'll leave it where it is. Okay, so what I want to talk about today is statistical preparedness in a pandemic. And the reason for doing this is that, although in many ways it's been an absolutely dreadful year, in terms of the role of data and statistics and science, I think it's really come to the fore. It's made a huge difference to the way the pandemic has played out. It's enabled political judgments. And I think it's worth having some reflection on what's gone right, what's gone wrong. So what I'd like to talk about comes under several headings, and I won't give equal time to all of them, but I think it's worth fleshing out. First of all, and it tends to come relatively early on, modelling to inform policy. So talk just a little bit about that. Diagnostic tests have played a big role, and there's been a lot of controversy on them. So again, I'll say a little bit about that. The surveillance of an epidemic, seeing how it plays out, what's going on, who's getting it going up and down, is something that I've had some quite major involvement in. So I'll give a bit more sort of chapter and verse on that. I want to say something about trials of therapies. Again, I'm as well as being a statistician, a lot of my work over the years has been in trials, so unsurprisingly, I've got involved in that. And I think there's been some very interesting things which have built on us being prepared. And then I'll say a little bit about trials of vaccines. And I hope I'm going to leave some time for discussion, because what I'm really trying to do is to get people thinking, and you may well have things to add that you know about or things that you want to critique. So let's start with thinking about the modelling. At the beginning of a pandemic, you haven't got much data, but when you realise there's a problem, you rapidly need to make judgments. And I'm not directly involved in this, but I should say I'm at Imperial. Many of my colleagues are involved in it and played an absolutely key role, but so have people at School of Hygiene, University of Warwick, and several others. I've not listed them all. And I think one of the things that's been impressive is the way that those groups have done their separate modelling, come together, informed government, talked on the radio and so on, so that public have got a better clue about what the debates are. They may not agree with them, but at least they know. So if I can roll you right back to, we were talking about the beginning of 2020, the pandemic broke in the very first few days. I think that the cases have actually been observed prior to that. And there was a sort of sense that what was happening was a few things which had jumped from animals into humans, and it was all very unpleasant for those people in Wuhan, but probably nothing too serious for the rest of the world to worry about. And then suddenly, and it was my colleague Neil Ferguson and his group who did this, they suddenly said, no, this is a much bigger problem than we know about. And that was on the basis of mathematical modelling. That was on the basis that a very small number of cases were diagnosed, not in Wuhan, but in other places where clearly the people had come on the plane. Now, not that many people in a short term fly out of Wuhan. So what they did was some back calculations, say, well, if we've seen that number of cases and knowing roughly how many people and what small fraction of the population might be flying on a particular day, and therefore over this small period, we must be drawing on a pool of several hundred cases. And the reason that mattered was it suddenly changed from saying this isn't just something contracted from animal to human, which is nasty, but it's never going to spread very far. This must be human to human transmission. And that changed the debate. That was when as I understand it, the Chinese government then said, yes, actually, we think that's what's going on. But it made the rest of the world take it seriously. So as I said, very, very few observations in terms of data. So the modelling was absolutely critical. That group have carried on doing modelling, and there's people in there who would regard themselves as modellers, people in there who'd regard themselves as statisticians, and plenty of others. And they've put out regular reports. And if you want the detail. It's all available on Imperial websites. But the one to flag up for the purposes of today is really what is known as Report 9. And what they were doing here was looking at we didn't have pharmaceutical interventions then that we knew would work. So what's the impact of non-pharmaceutical interventions to reduce the curve of mortality and healthcare demand? Because by early March, the concern in government and other places wasn't so much the illness, that's a problem, but it was the realization that if we didn't do something, we'd be in the same situation as Italy were, which is hospitals absolutely overwhelmed and doctors having to make invidious choices about who got the available ventilator and who didn't. So what this graph looks at is what would happen if nothing was done. What would happen in various scenarios? And that includes case isolation and household contacts and so on, and general social distancing. And it also includes the option of closing schools and universities, which at the time seemed absolutely unthinkable. But the key one in here is the red line, and the bottom half has that magnified up, because that red line is the surge capacity in critical care. So critical care has a certain capacity, and most hospitals are set up that if something happens, it might be a major rail crash or something in their area, that they can step the thing up. And so once that red line is breached, it means the hospitals aren't able to cope. And it became very obvious very quickly that unless the government started doing some of these relatively draconian things, we were going to have serious problems. And it was certainly when that report came out, until very recently, my last day in the office was the 13th of March. So 16th of March was the Monday when I saw this. And about a week later, the government said, no, 23rd of March, work from home. So this modelling, and there will be some time that others were absolutely game-changing. And in terms of the preparedness, this wasn't just a few people on a Sunday afternoon thinking, oh, well, let's see what we can model. I mean, there's some of that going on. This comes from the MRC Centre for Outbreak Modelling, and they are set up to look at both things like malaria, which are long-standing, but also they've looked at Zika, the resurgence of Ebola, they looked at H1N1, they've looked at SARS, MERS. So their job is to do this. They have code ready to go. Obviously, is priming with parameters and assumptions, but there's expertise there so that when a new virus comes along, they can do it. So this didn't come out of nothing, and you can critique it, and there's been plenty of critiquing of whether it was fit for purpose, whether it made the right assumptions, but my goodness, we were in a better position than if we did nothing. And I don't think they were actually too far wide of the mark. So we could talk for the whole seminar about modelling, but I'm no modeller, so perhaps just move on. And diagnostic tests was something, a year ago, when one or two people I knew who worked in medical school got COVID, I mean, most people were assuming it was working out by symptoms. And then I knew one or two people who knew that they had it because they had a test. And it was almost kind of, you had to whisper, because having access to a test was something you pretty much had to know someone or be associated with the government. Whereas now, of course, they're literally being given out outside of supermarkets. So again, I think we shouldn't throw out the baby with bathwater. There has been the most fantastic development of tests and use of them and deployment. I think, that hasn't been such a success story. These, statisticians, we understand about sensitivity, specificity. Lots of these have been developed quite quickly, and some of them haven't been evaluated in the settings in which they are then used. And I prepared my slides yesterday, so I couldn't put in anything more than that. But actually today, the Royal Society has launched a report, it's been a long time coming, on how you properly evaluate diagnostic tests. I've co-chaired that with John Deeks. John Deeks is absolutely the expert on these things. And that lays out in granular detail what needs to know, and there's sets of recommendations about what the right scientific basis is, what populations it need testing in, a batch of recommendations about the regulatory setup, which is not ideal at the moment for diagnostic tests. I think that's going to change. But at the moment, it comes under legislation, which means essentially there's not a lot of control over it. and then another set of recommendations about what needs to be in the public domain, because in the end, it's particularly the way they're being deployed at the moment, it is the public who are using them. And so they need to know what the evidence is. So there's stuff about what needs to be in the public domain. From the RSS's point of view, under my presidency, we got involved in a bit of critiquing of what was going on. So you may remember the moonshot, which sounded like it was going to save the world and actually didn't quite. And we were, in fact, it was probably this that made us start saying we need to put down more systematically what's needed. And suddenly we're front page of the Times. Experts criticising journalists over dangerous mass testing plans, and I think we upset one or two people. But it was a debate that needed having, and it's statistical issues at the fore. So there, the preparedness was people like John Deeks, who've done a huge amount of work on diagnostic tests in all sorts of diseases, know how you do them, what the things are to look for. And we pulled that expertise in very quickly. And I'll say a little bit more at the end about how the RSS went about doing that. So the next topic I perhaps want to spend a bit more time on is surveillance of the epidemic, because with an epidemic of a known disease, flus come every year, and we kind of know what trajectory they're going to follow. And we pay a bit of attention to whether they're, if it's more than usually in the elderly, frail population, and a bit more hospitalisation, we need to know about it. But they're kind of the shape of this known quantity, and if you like, it's just what the particularities of the curve is going to be. But we know they typically build up in the autumn, hit their worst kind of in the winter, and then tail off again and go away as the sun comes out. Whereas with this epidemic, we simply didn't know. And I'm not an infectious disease person. I've done a little bit on sort of respiratory viruses from time to time, but it's never been my major area. So I was as surprised as anyone when a group of us, a different group at Imperial, got asked if we would run some national surveys. And to cut a long story short, what we're now doing is a series of 2 national surveys, which are known as React 1 and React 2. And React 1 is antigen positivity. So that asks the question, if any of you have been sampled for that, and I seem to know a fair number of family and friends who have, that uses a test score that says, have you got the virus in you at the moment? React 2 looks at antibody positivity, which asks the question of, have you got antibodies to the virus, which at least in the early months was a pretty good way of saying, have you had it? And we'll perhaps come to whether that would work quite so well now. And in the early days, it just picked up, have you had the virus? As we'll see a bit later from some data, now it's picking up both the combination of who's actually had the virus, but also who has got antibodies because of vaccination. But we do those. React 1 happens on a sort of more or less monthly basis. React 2 rather less often, but I think we're about to come up with our 6th iteration of that. And those, as I think I'll show some data in a minute, show really nicely how that epidemic has played out. At about the same time, well, actually almost identical time, Oxford were commissioned with the Office for National Statistics to do a longitudinal study. So these are working, they're essentially asking the same kind of questions. Ours is cross-sectional, we invite different people each time. Theirs is longitudinal, but there's a lot of triangulation between the two. So if you've heard of either of them, broadly they're the same, but there's some interesting differences. But it's the Reacts that have been doing it Imperial. So that's the one I'm going to talk about. So let's go back to, and I should say these are commissioned by government. They feed regularly into government. I think government often see the early results before half the trial team have. And sometimes you can almost see sort of one of the politicians referring to something, you think they must have seen our results yesterday. But they come in the public domain very quickly. So if we go back to November, what you can see there is the pattern in the regions. And the reason it's sort of in watches is down to so we sample for about 2 weeks in 4. So we have periods where we've got data, which are the sort of bits going up and down, and then we have gaps and then 2 weeks more. So that's why that explains that sort of visual pattern. But what we've got is the different regions, and we've got London at the top, we've got the Northwest, that one there is the one you would be most interested in, the Northeast. And what was going on in most regions at the time was that it had been going up, and then partly because we went into fairly severe lockdown, it was dropping off, and we were all being promised a good Christmas. And certainly for those in the Northeast, it was a perfect. What you can see in, for example, the Southeast, which includes Kent, is the data really weren't doing that. It was doing some odd things, and to some extent in London. And I remember at the time looking at thinking, what is going on? They should all be doing, we should all be being like the Northeast, be more Northeast, be more Northwest. Didn't want to go as the Northwest had been, obviously, because that was a separate problem. People quickly realised was a new variant which was much more transmissible. I think it has higher viral loads, is my superficial understanding of that. And so actually, for some of us, that was why in December, Christmas got, but we could see it in the data released at the end of November, but it took another 3 weeks and said, no, we really do have to do something. But the surveillance sort of is one of the critical components of that. That was the data as at round 7. What you can see at round 10 is, so this is really data, if you like, this is the follow-on data. So this has got data in that is at the peak in January and then coming all the way down to March and April. You can really see it coming this at the April. It was all looking pretty good. And that has given a lot of confidence and has underpinned, along with other similar data, or other data sources, I should say, that has underpinned some of the easing of lockdown that we've seen. I haven't shown round 11, not, but the kind of thing we could do with the data, and again, these are only the series of reports we've done, but we were designed, it's only England, because it was commissioned by the Department of Health in England, but we deliberately do our samples to be able to look at quite a detailed level of resolution, geographical areas. So we sample a fixed number in each of the smaller tier local authorities. And you can see the difference in swab positivity between rounds 9 and 10, where you can really see these hotspots. It wasn't even over the whole country. It was very, very localised. And those lockdowns and other behaviour changes, because this was all pre-vaccine, in a very short while had a dramatic effect. But I think for me, the graph visually shows what's going on in ways that perhaps the overall averages only give us a glimpse of. So it really is phenomenal data, and I'm quite sure that these data are going to be keeping PhD students happy for many a time to come. But again, the preparedness on this was that I'm working with people like Paul Elliott. We also rapidly brought in Peter Diggle on the team, who's worked with Paul Elliott in the past. These are experts in spatial statistics. So then I won't go into the underpinning of this, but it's being done really rigorously. So what that gives me as a statistician is confidence. The presentations themselves are pretty intuitive, but it is based on top quality modelling. And of course, the design was also based on saying, well, what do we need to do? How many do we need to sample? So what other things can we do with the data? In a way, when we first started doing it, it was pretty pedestrian. We did these surveys, we put the numbers out, it sort of went up a bit and down a bit. But as they've gone on, we've been able to do more interesting things. And the next graph I'm showing you, so everything I've shown you so far is based on React 1, which is the have I got COVID? The graph I'm showing you next is actually reconstructed from React 2, which is have I had COVID? Now, you might think that these data, which basically show the course of the pandemic over pretty much the whole time, we didn't start back in March, but I think our first rounds were, these data take it from December. Oh, no, that's right. We started doing it from about April or May last year. But we can reconstruct right back to December. And the way we can do that is that we know from REACT2 who has had the virus. We asked about symptomatic infections. I mean, I'm sure you, if not yourselves, I'm sure you know people who said, well, I had a really nasty infection back last February or January. I'm sure with hindsight that might have been COVID. So we had that data. So the combination of knowing whether someone really had the virus and when they were reporting symptoms, we can reconstruct it. And actually, you can see that peak there, which is sort of around about the 16th of March when we shut down, talk about, well, it wasn't shut in the stable door off the horse had bolted. If we hadn't shut down then, you can visualize what that infection would have done, but we got a very sharp drop. And I think at the time we simply did the case, with hindsight, but with really quite clever back calculation, we can see that. Whereas the subsequent peaks we've had, and that one there is centred on December. So that's the Christmas one that was then abruptly brought to a halt by more or less cancelling the Christmas, are actually not as bad as the March peak. I mean, if that had gone on any longer, I think we really would have been in a bad situation, and we may well have had health service imploding. I mean, I know that in January, some of my colleagues who work in critical care, you're on phone calls with them, and you think, gosh, it doesn't want to get any worse, but said we did turn a corner. And of course, so I should say in January, that's about a month later than the infection, which is but how long it takes before people get into hospital. So that's just an example of what you can do once you've got a series of data. And again, I could talk a lot more about that, but I want to move on to talking about trials of therapy, because when this first came, we had almost no idea of how to handle it. If you remember, the discussion was all about how we got enough ventilators, which are what you would use for people with flu. And it turned out there were some people needed ventilators. Actually, they weren't so smart. They rapidly learned that actually proning people, putting them in their front, was in many ways more effective. But where I think the diagnostic tests, we've got a lot of things wrong, whereas I think in trials, the UK has got an amazing amount to be proud of. And I want to talk first, in this case, first about the preparedness, and then move on to the actual trials. So we're talking, most trials are, the typical trial are two arms. It might be a placebo and an active treatment, or it might be standard of care and then standard of care plus some new proposal. Or it might be your normal treatment and then perhaps half a dose to see whether you can actually reduce the burden of treatment. There's been a lot of talk about adaptive trials, ones that instead of having a two-arm trial and then stopping and then finding funding for another two-arm trial, are much more sort of living trials. And there's good examples, particularly in cancer. The Stampede trial is perhaps one of the most obvious examples. And back in January 2019, I was asked to chair at the Academy of Medical Sciences a forum meeting. Forum is meetings between the regulators and industry and academics on adaptive trials, and not so much the fancy statistics of them, but what is stopping them getting into practice. And we had some examples there. I've just mentioned Stampede, which is the prostate trial. We had an umbrella platform trial, which is one of the flavours of these for colorectal cancer. We had ALICE, which is an adaptive design for influenza medicines in primary care settings, and another one in Alzheimer's disease. And one of these I've been most closely involved with is ALICE, which was the influenza medicines. I chaired the data monitoring committee for that. So we had some expertise. We had a will to see these, which is why this meeting was taking place and the report that came out. But it really came to fruition that in March, several groups were discussing that this is what we needed in COVID. And within 3 weeks, these trials were randomising. So the announcement made, and this is managed to be joined up between England, Scotland, Wales, and Northern Ireland. They wrote to the hospitals and announced publicly that there were lots of trials going on, but they said there were sort of 3 national priority clinical trials, one of which is in primary care, one of which is in hospital, and one of which is in the critical care patients. So REMAP-CAP is in critical care patients. It was an ongoing trial, but they always had provision that if there was a pandemic, they could rapidly adapt. Recovery, you may have heard Martin Landry and Peter Horby talking about. And Principal was the reinvented Alice trial, reinvented influenza trial. So that's why I got a phone call to say, will you chair this data monitoring committee? It's not identical design, but it's similar enough that the structures were just kind of reactivated. So I want to say so the phenomenal thing, I mean, normally it takes about 3 years to get a trial like this off the ground, to get funding. 3 weeks from putting it through ethics to first recruitment is just amazing. And they have really come into their own. So the first of these, which is the one I know most about, is Principal, was probably the one that was slowest off the blocks in terms of recruitment. And so it may be the one you've heard least about. But nevertheless, we've had 5,000 patients. We've been on weekly data monitoring committees for a large part of it. Hydroxychloroquine was stopped by the MHRA for reasons I won't go into, but essentially it wasn't a trial-informed decision. And it was a bad decision as well. It was on the basis of a very poor external study. But azithromycin, which is an antibiotic, doxycycline, were both stopped for futility. They're not dangerous, but they were clearly showing no effective difference. And so we stood those down. Much more recently, so May this year, we've stood down an anti-inflammatory called colchicine. But the one thing I haven't got up there is I should be on here, is that budesonide, which is an asthma drug, has worked. And so we stopped for efficacy for that and put out a recommendation that in future, if somebody gets COVID in the community, budesonide is a good option and shortens time to recovery quite substantially. Current randomizations are an antiviral drug, and there's another one under consideration. So that has been a groundbreaking trial in all sorts of ways. So recruited through NHS 111, it's recruited through the Zoe app. So it's actually sort of rather bust the mold of what you mean by recruitment to trials. The second of these trials is the recovery trial, which is possibly the one you've heard most about. And that has recruited, as of yesterday, 39,967 patients. I dare say if I checked it out tomorrow, that will have bust the 40,000 mark. That is a phenomenal amount of work, but what it also means is that you can make good decisions quickly. So they have stepped down on the basis of lack of utility, that they don't work. Hydroxychloroquine, some lopinir, ritonavir, which are drugs that have been used in HIV before, convalescent plasma, about which there was a huge fuss, and colchicine, which is the one we stood down. But they've also managed to say dexamethasone, which is a steroid, has stopped for benefit. So that was in June, so that has changed the mortality experience. Tocilizumab, which is one of the monoclonal antibodies, has stopped for benefit. They've just stopped another arm because they've got good power. They haven't said what the results are yet. And again, there's about 3 randomizations going on currently. So they are continuing to learn. And then REMAP CAP, which is in the critically ill patients. This is too complicated to put into one slide. They've had about just under 1,400 randomizations. So far fewer patients get critically ill, a lot go into hospital, but fewer go into hospital. But, this must be one of the largest, if not the largest trial in critical care ever. And again, they show that the drugs that are used for HIV are ineffective, that dexamethasone is effective in this setting, corticosteroids improve recovery, the monoclonal antibodies improve outcomes, including survival. And this is a very complex trial design, partly because the number of different reasons you end up in critical care are phenomenal. But basically, they've got 14 domains with 46 current or completed randomizations. So depending what mixture of horrible things you go in with, you will be offered randomizations across those uncertainty. And to me, this is game-changing. It's game-changing for COVID, because this really has improved mortality experience during the course of what is quite a short pandemic. But I think it's also game-changing for what we might do in future, because if you can do it in these diseases under pandemic conditions, then actually you can organise trials a little bit better under more normal conditions. So, again, we could talk about each of those extensively, but it would be remiss of me not to at least mention trials of vaccines. And this is less of my expertise. So all I'm really going to say, I think this tweet says it for me. This was from someone called Sheridan Vosey, but what he was tweeting, it took him the second tweet to actually put her name up, Marin, she'd been the lead statistician on the AstraZeneca trials. And he was just saying, the team has done in 10 months what it would normally take a decade to do. And I think that's also true of the other science. But that group are ready to go with it. And again, whatever the debate's about whether AstraZeneca could have done it better, what the learnings are, whether it has side effects, I think to get to where they did in the time they did in a publicly sort of run trial is nothing short of phenomenal. But she also stands surrogate for all of those statisticians on the other trials and those in pharma who've done something similar, because Chris Whitty said very early on in the pandemic that science would get us out of this. He didn't know which science, but science would get us out of this. And to a very large extent, vaccines are the workhorse of what is going to return life to something which is nearer to what we would like it to be. So in REACT, we've done some interesting triangulation on what the effect of these are. So these data I will try and take you through, because these are from the last reported round of REACT 2, which is the who's had it. And this came out at a stage when quite a lot of people had had at least one dose of vaccine and a few had had two. Now, those that had had 2 doses of vaccine, there was no doubt that 3 weeks out, 95% of them had antibodies. But the interesting question is what happens to those who'd only had 1 dose? And we've got here data on the under 60s, those people in their 60s, those in their 70s, and those in their 80s, into the numbers in each group down here. But what this shows was what happened in those who hadn't had COVID, which are the pale blue lines. So the confidence intervals are relatively narrow because that's most people. And then what happened in those who had had COVID. And you can see that in those who had had COVID, by about 3-4 weeks out, most of them, in fact, nearly all of them had antibodies. So for those who have had COVID, essentially your first dose is acting as your booster. For those who haven't, it takes longer if you're under 60. So if you're a youngster, as we might call them in this context, it gets up there fairly quickly, but it starts to tail off. And for those in the older age groups, actually on 1 dose, they're not even getting up to half of them having antibodies. And again, you get a sense of tailing off. So that's a real worry. And it's, I think that is partly behind, and I'm sure they've got this data on individual patients as well, at least the companies should have, behind the encouragement that we really do in that second dose. And I think, although this wasn't on variants, that's even more true of those with variants. So it's interesting that cross-sectional data, and this is cross-sectional data, this isn't individuals followed over time, really give you quite a sharp clue as to what's going on. So we were rather pleased with that, but it took us a while to get our heads around it. REACT has now gone, I've shown you so far from REACT 1, round 1 to 10. What I want to show you from round 11, which reported last month, is a rather nice analysis, because of course the question, the reason that looking at infections matters, I mean, infections are nasty, there's no 2 ways about it, but what really matters if people then go into hospital and go on to die. So what this analysis is the black lines are the infections, but the red lines are the daily deaths, but they're not plotted in real time. They're plotted with a lag. And what you can see is that with that lag, and I think it's of the order of about a month, it was absolutely tracking the pandemic. So if it went down, you knew that deaths were going to go down a month or so later. And if it comes up, they were going to go up. And what has happened since the beginning of this year is that they've started to decouple. So these, again, are part of the data that give us confidence that the vaccine is resulting in fewer deaths. And obviously, at this stage, some of the population are vaccinated, some aren't. But because of the way the vaccination was done, it was in those most likely to die. But that, to me, is pretty good news. This is the same for hospitalizations. It's dropping off less fast, but I think, at least with the eye of faith, you can see that hospitalizations are beginning not to track. So we've got round 12 reporting next week. So I'll be for all sorts of reasons, I'm going to be very interested to see what those data say, because although the data are in, I haven't actually seen those analyses yet. So if you're interested in this, watch out. I think it's probably about next. It's typically on Thursday that it's press release, so we'll see whether that happens. So there's all sorts going on. I've shown you a sample of the statistical things, but by no means comprehensive. So when I was president of the RSS at the beginning, people said, oh, what's the RSS going to do? And I must say my initial reaction was not a lot. Some of our people, including my colleague Crystal Donnelly and others, are thoroughly involved in dealing with the pandemic. We don't want to make life any harder for them, but actually we pretty rapidly thought we were focused on the modelling at that time, but there are going to be other issues coming up. We need to set up a task force. So I asked David Spiegelhalter, who was my predecessor as president, and Sylvia, who's the current president. I mean, not so much because they were past and future presidents, but because of the skills they had, and put together a team who basically acted as coordination so that if requests came through, they knew to pass them on. What they did was some forward look to say what might be coming up. And their remit as that task force is to look at design of data collection, diagnostic studies, the modelling we've talked about. They've done much more on forecasting, the treatment studies, but also, and of course, this is where David plays a blinder, is in the enhancement of public understanding. I mean, he's been on the radio so much, just talking so much sense. I've just listened to the More or Less podcast for this week, and he's bringing sense to what's going on at the moment. So they set that up, and one of the things that they didn't necessarily do all the work, but they knew who to call on. And one of the things we had not seen coming, we were focused on health. We hadn't thought that one of the biggest things of my presidency was the exam route. You may or may not, from last summer, and couldn't go into school to take their exams. Ofqual, they came up with a way of sort of assessing them, which was rather embedded, it rather privileged those in the small private schools and not those in the larger schools. And the RSS had seen this coming and written, and then on exams day, all hell broke loose, and we wrote and said, look, didn't quite say we told you so, but it was hard not to say something fairly similar. And of course, the newspapers picked it up, and there was an almighty row, and Ofqual weren't terribly complimentary, but we sort of stood our ground. And actually, there's no investigation going on, and I know David Spiegelhalter has been involved. I think it's David, yes, has been involved in that. So they are trying to come up with something more sensible, but that's, again, it's the unexpected, but we've got people who've done good work in education and done the thinking, which meant that when it came, we were ready to do what we needed to do. And what that group have done, and this is what I'm going to use to finish off with, is put out 10 statistical lessons that the government can learn from the past year. So one of those is to invest in public health data. Where we've had it, it's been great, but where it wasn't available or wasn't being properly sort of collated and put out to the public, we've had some difficult debates. They do need to publish the evidence. Early on, there was just a bit much secrecy. I think some of the other sort of health emergencies have been over almost before anyone's realised. And so it didn't matter. Whereas when you've got something that's going on for this length of time, we need that evidence to be out there so the public know what's informing government. You need to be clear and open about the data. It's not all perfect by any means, but that doesn't mean that you can't be open about it. Challenging the misuse of statistics, the RSS is pretty good about that. And the media, I think the media has stepped up to its responsibilities pretty well, but they need to do it even more. We need to build decision-maker statistical skills. A lot of the debates have really been because people didn't fully understand some of the issues they were dealing with. And again, it's a lot better than it could be, but it's not as good as it needs to be. We need an effective infectious disease surveillance system to monitor the spread of disease. REACT has been great, but we put that together in about a week, and I think ONS put their protocol through in about a week. And that was building on tremendous experience of doing epidemiological studies. But there should have been something rather like the trials where they were activated, ready to go, so we can be more prepared for that another time. Openness and scrutiny for new diagnostic tests, and I've already said that almost as a spring off from this overarching working party, we've had a sort of sub-working party which has just put out this rather detailed report, but it's got both principles but also a lot of examples of where things have gone wrong. there's been a lot of good health data around, but a lot of this is about social care. I mean, one of the horrors was what happened in the homes for the elderly, and that data just wasn't available. There just wasn't an understanding of what they did, how they functioned. So you need, and not just those, but there's going to be a sort of legacy of COVID, which will need more social care. So we need that data, or those data, and evaluation should absolutely be the policy. Some of what we're seeing is very policy informed. I mean, clearly it has to be balanced against other considerations, and some is absolutely not. An evaluation needs to be there absolutely all the time. So none of this is news to statisticians. The point I'm making is that the RSS have put this out sort of as a basis for what we can learn from the past year that should stand us again in good stead to be prepared for further infectious disease pandemic, well, further COVID work actually, further infectious disease pandemics, or indeed for other disasters that come along unexpectedly, but we need to sort of collect data on so that we can work out how to address them. So I'm going to stop there. I think I've achieved my objective of leaving a bit of time for discussion. So I shall stop sharing my slides. I hope that's worked. Yep. And hand back to Kevin.
Thank you very much. So can we thank Deborah in any way that we're able to over Zoom, please? There we go. Some good innovations there from some of our own.
And the high-tech sort of hand signals. Brilliant.
Okay, I'll open the floor to questions. And again, if you can attract my attention in any way that is going to attract my attention, then that would be great. So you can try and raise your hands and I might notice, or you can just shout at me and that would be fine too. Chris and Sandra, is it? If you mute yourself, you can ask a question. You're still muted at the moment, I'm afraid.
Is that better?
Yeah.
Initially, when you started up with the trials,
yep,
it would be very difficult to decide if a person had COVID or not.
Yeah.
I mean, I've asked around and I found out that I think I had it.
Right.
But I think a lot of people who actually had it didn't think they'd had it.
Mm.
And I find that very difficult when you come to doing trials. How do you get around that?
Well, you don't get round it. It's a pandemic, so you have to live with it. So I think the second group who didn't actually know they had at the time probably wouldn't have been going anywhere near the GP asking for treatment. But what it means is that the recruitment criteria of the trials has shifted. So early on, it was on the basis of symptoms, and we've got data. Very few people had positive tests for that matter. Very few people had negative tests. And tests became more, the proportion tested went up, and actually recruitment for that trial, or at least not the recruitment, but the primary analysis of that trial has now shifted to the COVID positive. So. Right. But from the point of view, it's a pragmatic trial. So we had a lot of discussion about that, and Data Monitoring Committee kept asking questions saying, what should we be doing? And early on, the GPs quite rightly said, all we can do is treat symptomatically. That's the question we need the answer to. Whereas now you can get a quick test.
Yeah.
And so, I mean, even PCR is pretty quick in this context. And so you can say, we want to know what happens in COVID positive people. And the recruitment trial and the analysis aren't necessarily identical, but so there's been that. But what it does mean is, in looking at the results, those treatments that are tested early will have been tested on a sort of what's probably a sort of mixture of people, especially as it was over winter, whereas over time it's become a much more COVID clear population.
Right.
But I think the key thing is you have to be very clear what question you're asking. And if you're asking a pragmatic one of what on earth should GPs be doing now, and if a treatment is good or needs stepping down, it needs stepping down now, you should do it. But when we come to interpret the trials, and if people are then doing meta-analysis and things in 2 or 3 years' time, that's a context they need to be aware of.
Okay, so there's someone with their hand up. David Neville, you have your hand up. Do you want to ask a question?
Hi, yeah. Can you see and hear me?
Yep.
Hi there, yeah. So yeah, I really agree with the point you made around the care home horror, I think, as you called it, and the data that was unavailable to, well, as quickly as we wanted to be able to sort of add evidence to what we thought was happening. And I work a little bit in that space myself. But so I think you probably accept that one of the issues there is not just that the data doesn't exist, but it's the connectivity and the fact that they're just generally not as digitally mature, and it's such a dispersed system. Do you think, I mean, just personal opinion, how much weight do you think this line of work and the need for that stats adds to what would be a pretty massive business case to say you need to really ramp up connectivity, consistency, and just general digital maturity in that sector in its own right? I mean, obviously there's loads of other use cases for it, but I guess how big a case do you think we can make from a stats perspective?
I think, like a lot of things, what COVID has done is bring into sharp focus things that were there anyway. So yeah, if you remember, Department of Health, what was Department of Health is now the Department of Health and Social Care. So social care has been coming up the agenda in a broad sense. And lots of people have been having to do some thinking. So when I was involved in trial funding, we suddenly had much more of an obligation to fund trials in social care. And then you realise the systems aren't there, the checks aren't there, so the data aren't there. It's a much more, I mean, I've spent some good time when I was a student working in our people's homes. It's a much, I mean, that was a long time ago, but it's still a much more mixed economy. And that makes it much harder to study. But I think what this has done is really shine a spotlight. And this is an evidence of what can happen. And I'm sure is actually happening at a chronic level absolutely all the time, but is then an absolute disaster. So I think it can be used. I mean, I'm not holding my breath, it'll all be sorted out really soon, but it does say, look, this is woeful compared to what it could be. So I'm
cool. Thank you.
I think it's really important. I wouldn't say I'm optimistic it'll be sorted by the end of the year.
Yeah, I'd agree.
Yeah, there's genuine questions about how to do it. There are some things you say, look, this is what ought to be done, and we just need to do it. And there's other things you really have to think through. How do we do it? How might you bring in systems? We've done it. Primary care at one stage was, every GP with their own sort of collection of sort of paper notes filed in a different way, and we're now much more usable data. So I think it's not impossible. It's really important.
Well, thank you.
So we still have a little bit more time for any more questions. So
somebody's put a question in the chat.
Question.
Oh no, she put a comment in the chat.
Yeah, it's just a comment. It's fascinating. It's always fascinated me how some people get affected and some don't, even when they're adjacent to each other. And looks like there might be some progress now to try and get a handle on that. It seems it was just announced today.
No, that would be. It doesn't help those who've already had it, but understanding exactly, because it's a sheer variation in the experience. You say from plenty who have it without even asymptomatic, and that's why React really mattered. I should emphasize, because what it picked up was the asymptomatics, which aren't picked up by any other data route. Whereas through to those that have the most horrible experience, and even what's called mild COVID, the people I know have had so-called mild COVID, meaning they didn't get to hospital, it still sounded pretty nasty. And that's before it turns into long COVID. So anything that helps understand would be really valuable. And of course, that also what genes often do is then help tease out what the mechanisms are, which then can give clues to developing new treatments. So there's all sorts of reasons for wanting to know that.
David, did you have a second question there? I see you put your hand back up.
Yeah, if there's no one else, I've got another question. It's a different theme, and you touched on it a little bit in the chat as well around, it was a bit of a gold mine for sort of fake news and sort of like adverse campaigns through COVID. And some of it just, probably just, not ill-intended, people were just misinterpreting stats. And the likes of, so like you said, David Spiegelhalter did loads of great work to try and make them a bit more plain English for people so people understood what was floating around. But do you think there could have been more of a role for some of the formal organisations, whether the Society, ONS, whatever, any of the organisations to do more rapid response to any fake news type stuff? And there are a lot of sort of fact checking things that came out. The BBC ran its own fact check, reality check. Do you think there's more of a role for things like that from the stats organisations?
I mean, I think what we should, as you say, BBC and they've now got Robert Cuff, who's head of statistics, so he does a great job, and Full Fact, who do a lot and again work closely with the RSS. So I think working through those organisations is probably the way to go. So they can respond. I think, though, that so where there are just misunderstandings or a newscaster says something wrong because the reporter said it a bit wrong, that can go down very well. I think a lot of the time there's a much deeper distrust. So I've sat in on, because the area I live in, they've had various things aimed at our local community about vaccinations, and you suddenly realise that a lot of it's about ethnicity. Deep distrust, which is goes back generations, is very well founded in many cases, and that's then playing out with, well, what's this vaccine about? Why should I trust people now? And actually understanding, I think this online event actually did something to help people sort of not just get it off their chest, but to actually explain and verbalise what the issues were. And it needs addressing there. And I think for that kind of thing, fact checking is only a tiny bit of the solution. Obviously, you want to factually correct things, but it doesn't deal with a much deeper rooted problem. But where it comes from just misunderstandings about statistics, or then it can go a very long way. And also debunking some of the wilder myths. I mean, the 5G stuff and so on. I think at least putting stuff out there. So for those who are sort of thinking, well, surely I shouldn't believe this, have got an alternative narrative that they can choose between. So, and many people are genuinely uncertain. It is hard to know what to believe. So I think it's really important. It's just not quite the whole story. Vaccine hesitancy, which is, so some of the language matters, saying people refuse to have vaccine isn't helpful, but thinking of it as vaccine hesitancy, people just aren't quite sure what to do, is probably a much more constructive way of tackling it. And so some of it's fact checking, some of it's more behavioural, actually talking to people and trying to understand what their issues are as well as anything else.
Yeah. That's useful, thank you.
Okay, we've got a few minutes left that we could use up, so I'm happy to take one more question if someone has one.
I've got one, but it will be broadening the discussion. Is that okay?
As long as you can ask it and get a response in 3 minutes, then absolutely.
All right. Yeah. I have difficulty with the definition of excess deaths.
Right.
The reason being, everybody will die eventually. So the concept of excess deaths loses out in terms of its usefulness in long term, because there are fewer deaths than have been expected in certain months now than what you would have had, because people who died of COVID earlier are now not dying because they're already dead. So I have a problem with excess deaths. Now, I have to say I haven't been able to come up with an alternative apart from months lost of life, which is quite, I don't know if it's any better or any worse. It's probably much more difficult to calculate, but at least it's a more general description of what is actually required. So if someone dies when they're 20 and you expect them to live to 70, that's 50 years of lost life, so 600 months. And that seems, if someone is 90 and gets COVID and dies, well, they're only expected to live 5 more years, that's 60 months. So that gives you a better picture, better handle on what's going on than simply the number of excess deaths.
But I think I think you're right in many ways, and excess death is a kind of shorthand, and I think it's actually been quite good for getting debate going about what do we mean, and we've had deaths due to COVID, or is it more what we expect sort of. So I think what you're describing, I would say, is very much taking quite rightly an individual perspective. From an individual point of view, we're all going to die sometime. What we're trying to avoid is those things which take off a large chunk of relatively healthy life. And I think those kind of metrics, life lost, which economists actually use in many contexts, are the useful ones. And I have heard those in COVID, that you might lose about a decade is, I think, the figure that don't quote me on that, but there's something of that sort. I think where excess deaths is more useful when you're taking population perspective, and then you're saying at the population level, how many more deaths have we had over this, and you have to have a time frame for it.
You do, yeah.
Over this month
Yes.
compared to last year, over the year compared to last year. So I think, but the key thing is say, what's the question I'm trying to answer? And then a lot of it falls into place. We could have a longer debate, but I'm very, very conscious of time, but it's a really good question.
Yeah. Thank you for the response, keeping us just before 5 o'clock. So I'll wrap us up there so that we are finished at least before 5:01. I'll remind everyone that we have some talks coming up. So on the 27th of September, we have Martin van Smeeten, who's going to talk to us again, another pandemic-based topic. So he's going to talk to us about COVID-19 prediction models. And so you'll get some emails from Amir about that fairly soon. And then slightly later this year, the 15th of November, we're going to have Professor Christina Yap, who's going to talk to us about efficient trial design. So we've got a couple of talks coming up. But just before we go, can we thank Deborah again for an interesting talk and a good question and answer session as well?
Thank you very much for inviting me. And I hope to get up to the northeast in not too long if we can get the science right. And maybe I'll be allowed to come up and say hello properly.
Thank you very much, everyone.
Thank you.